Imagine this, right? A serious accident, maybe a big car crash, someone falls from quite a height, or even a really bad sports injury. And the result is a major bone fracture. We're talking femur, maybe the pelvis. The emergency crew gets there. They do their amazing work, stabilize the patient, stop the bleeding, get them ready for the hospital fast. They handle the obvious stuff. But here's the thing. Even while they're doing all that, something else, something hidden, is starting. A sort of silent threat coming from the inside of that broken bone. So what are these hidden risks? What happens when those big bones break, even after they're stabilized? That's exactly what we're getting into today. Our deep dive is focused on a really critical and honestly often overlooked medical problem: fat embolism after major bone trauma. We're not just talking about the problem itself. We're digging into this fascinating two-part paper by Dr. Arie Neymotin, a radiologist. It's more than just identifying an issue. It lays out a whole interconnected research plan, a way forward.
Our goal here is to pull out the key insights from these papers, see how they fit together as this complete research proposal, aimed at really improving how patients do. It's kind of blueprint for future trauma care. Okay, let's unpack this.
Yeah, and what's fascinating here is just how vital this topic is. We're talking about a potentially lethal complication of major trauma, and crucially, it's something that frontline folks, especially emergency radiologists, are in a unique position to actually spot early on. Dr. Neymotin's perspective as an emergency radiologist is so valuable because, well, he's often the first one seeing those subtle signs on the scans, That gives him real insight into why early intervention is so critical, and the way he structures the work is really helpful. Part 1 lays out the problem, what fat embolism is, and the one main thing we do right now in the field. Then Part 2 looks ahead, proposing specific research directions, things like better detection, new interventions. It's all about building a more proactive approach.
Right, so let's start there with really understanding this threat. Post-trauma fat embolism. What exactly is it? Well, at its core, it's pretty straightforward. Fat from inside the bone marrow gets into the bloodstream after a major fracture.
Yeah.
But how does that happen? And why is it such a big deal? Okay, picture a long bone, like your femur, the big one in your thigh, or your tibia, the shin bone. Inside these bones, especially in adults, there's this stuff called yellow marrow. It's mostly fat stored right there in the central part, the medullary cavity. Now, when one of these bones breaks with a lot of force, it's not just the bone snapping. The tiny blood vessels all around it often tear too.
Exactly, and that creates a direct route.
A pathway, right, for that soft, fatty marrow to just escape the bone and get pumped straight into the circulation. It's like an internal leak you can't see.
And it's not just any fracture. Certain breaks carry a much higher risk. It often depends on the bone itself, how much fatty marrow it contains, or the kind of trauma involved.
Like the femur, you mentioned that one.
Yeah, the femur is top of the list, highest risk simply because it holds so much fatty marrow. But the pelvis, the humerus, your upper arm bone, and the tibia are also major players. They're often involved in those high-energy injuries.
Okay, so the fat gets out. What happens then? These little fat droplets are now floating around in the blood.
And they're definitely not harmless. They travel quickly through the bloodstream. Because of their size and nature, they can easily block the tiny capillaries, especially in the lungs. Think of it like clogging up the filter.
The lungs are the first major filter they hit.
Precisely. They get stuck in that delicate network where oxygen exchange happens. But it's not just a physical blockage. That's only part of the problem. These fat droplets also trigger a massive inflammatory response. The body basically sees them as foreign invaders.
So it's a double whammy: mechanical blockage and inflammation.
Exactly. And that inflammation isn't just in the lungs, it becomes systemic. It can damage other vital organs too, the brain, skin, kidneys.
Which can lead to multi-organ failure.
Potentially, yes. If it's severe and not managed quickly, that combination of blockage and widespread inflammation can cause organs to start shutting down. A really devastating outcome, especially for someone who seems stable after the initial injury.
Wow. So this moves way beyond just a broken bone problem.
Absolutely. It becomes a systemic crisis. And the most recognized severe form of this reaction is called Fat Embolism Syndrome, or FES.
Okay, so fat embolism is the event fat getting into the blood. FES is the body's reaction to it.
You got it. FES is the clinical syndrome, the collection of signs and symptoms that show the body is having a severe reaction. And the numbers, well, they're significant. FES happens in maybe 0.5% to 2% of people with just one isolated long bone fracture.
Okay, that seems relatively low, but still concerning.
Right, but watch this. In patients with multiple major injuries, what we call polytrauma, that number can jump up to 10%.
10%? That's huge.
It is. And when FES develops, the mortality rate is around 10% overall, maybe even higher in older patients or for those with really extensive injuries.
And you mentioned diagnosis is tricky.
Very tricky. The symptoms can be subtle at first, and they often mimic other things you see after trauma, like shock or a head injury. This delay can be dangerous, but clinicians are taught to look for a classic triad of symptoms. When these three show up together, it really raises the suspicion for FES.
Okay, what's in the triad?
First, dyspnea, severe difficulty breathing. That's the fat hitting the lungs, messing with oxygen exchange.
Yeah.
The patient might suddenly get short of breath, need more oxygen.
Even if they seemed okay initially.
Exactly. Second, a petechial rash. These are tiny, pinpoint red or purple spots, like little bruises under the skin.
Where do those usually appear?
Typically on the chest, neck, under the arms, sometimes even in the whites of the eyes. It's a sign of the fat damaging the smallest blood vessels, the microvasculature.
Okay, breathing problems rash.
Yeah.
What's the third?
Neurological changes. This can range from confusion, agitation, disorientation, all the way to seizures or even a coma in severe cases.
So lungs, skin, brain. That really highlights the systemic nature.
Absolutely. And the timing is key too. These symptoms usually develop within 24 to 72 hours after the injury, not immediately, which adds to the diagnostic challenge.
Right. The patient might seem fine for a day or two and then suddenly deteriorate.
Precisely. The brain and lungs are especially vulnerable. And like I said, it's easy to mistake these symptoms for something else if you're not thinking specifically about FES. A high index of suspicion is crucial.
And are there other complications besides this classic triad?
Yes, FES is the main syndrome, but fat embolism can cause other specific severe problems too, like Acute Respiratory Distress Syndrome, ARDS. This is a more severe form of lung injury caused by the fat emboli, leading to profound hypoxia, dangerously low oxygen, and often needing mechanical ventilation, intubation.
So needing a breathing machine.
Right. And then there's cerebral fat embolism.
Yeah.
This happens when fat droplets manage to get to the brain,
How do they bypass the lungs? I thought the lungs were the first filter.
often through a small hole in the heart that some people have, called a patent foramen ovale, or PFO. It allows some blood, and thus fat emboli, to shunt from the right side of the heart to the left, bypassing the pulmonary circulation.
Ah, okay. And fat in the brain causes.
Widespread microblockages and inflammation. This can lead to neurological collapse, severe delirium, stroke-like symptoms, seizures, and in the worst cases, brain death.
That's terrifying.
It is. And a key point Dr. Neymotin makes is how often these are missed if FES isn't actively considered. That delay in diagnosis can have devastating consequences.
So it sounds like the impact is truly body-wide.
It really is. The paper also mentions things like coagulopathy, problems with blood clotting, sometimes even DIC, disseminated intravascular coagulation, where you get both clotting and bleeding paradoxically.
That sounds incredibly complex to manage.
It is, and you might even see retinal fat, emboli fat in the tiny vessels of the eye, causing maybe mild vision changes, less severe, but it just reinforces how widespread this can be.
So, thinking about the emergency radiologist again, they might see signs of this before the patient shows these severe symptoms.
That's the critical link.
Wow.
They might see, say, that patchy snowstorm pattern in the lungs on a CT scan, even if the patient isn't profoundly breathless yet.
Or maybe subtle brain changes on an MRI.
Exactly,
Yeah.
like that starfield pattern of tiny bright spots. These imaging findings can be the very first alarm bell. And that's where the paper's core insights really start to connect, showing how radiology can bridge that gap for earlier action.
Okay, that makes perfect sense. Which brings us to the first line of defense mentioned in the paper. The sole pre-diagnostic defense, as it calls it. Immediate immobilization. And this isn't anything high-tech, right? We're talking about basic stabilization, using things like splints, maybe traction, or even just carefully holding the limb steady. The idea is just to stop those broken bone ends from moving around.
Right, it's fundamental.
Like putting a lid on it quickly. Trying to stop that pumping action that pushes the marrow fat out. And it needs to happen fast, like right at the scene if possible.
Absolutely, as early as humanly possible. It's about minimizing any further movement right from the outset.
And how exactly does that simple action help so much?
Well, the mechanism is straightforward but powerful. By stopping the bone fragments from moving, you directly prevent that mechanical pumping of marrow fat into the torn vessels. Every little movement can squirt more fat out. Immobilization stops that.
Makes sense. Like stopping the source of the leak.
Precisely. But it does more than just that. It also helps reduce further tearing of blood vessels around the fracture. It minimizes more bleeding, lessens damage to the surrounding muscles and tissues.
Okay, so it contains the damage locally too.
Yes. And practically, it makes the patient much safer to handle and transport. It reduces their pain, prevents the injury from getting worse while they're being moved to the hospital for definitive surgery. It's really the foundational step.
And you mentioned its universality, that it's used everywhere.
That's what's so remarkable. It can be done immediately, right there at the scene. First responders, paramedics, even trained bystanders can do it. It doesn't require waiting for x-rays or a full diagnosis. It's based on suspicion of a major fracture.
So it's truly a first-line immediate action.
Absolutely, and that's why it's implemented universally. Military medics use it, rural EMS, urban trauma centers, everywhere. It's globally recognized as step one in managing these injuries.
Its widespread use must mean it's integrated into standard protocols then.
Deeply integrated. Think about protocols like PHTLS, pre-hospital trauma life support that guides paramedics. Immobilization is right there, front and center. Same for hospital protocols like damage control orthopedics, DCO, which focuses on rapid stabilization, or early total care ETC, which aims for definitive repair later. Both rely on that initial immobilization.
It's the bridge to further treatment.
Exactly. EMS guidelines everywhere mandate splinting for suspected long bone fractures. And to really drive home its importance, the paper points out that for femur fractures, applying a traction splint is often prioritized by first responders, even over giving pain medication initially.
Wow. That says a lot about how critical it is. It's not just comfort, it's about preventing this systemic catastrophe.
Precisely. It's the simplest yet arguably the most critical immediate defense we have against fat embolism.
Okay, so immediate mobilization, vital, fundamental, universally applied, our best first step.
Okay.
But, and this is a big but highlighted by Dr. Neymotin, right? It's not enough on its own.
That's the crucial transition point in the argument. While TUIS is essential, it doesn't completely eliminate the risk.
So despite splinting and traction, fat can still leak out, or maybe enough has already leaked out before immobilization was fully effective.
Exactly. The systemic risks remain a serious concern, and this is especially true from the perspective of the radiologist, who might still see those subtle signs develop later on imaging. And the stark reality, as the paper points out, is that right now, there's no other proven intervention. No drug, no specific surgical tweak, no diagnostic test that's routinely used in that very early pre-diagnostic phase, specifically to prevent the fat release itself. Immobilization stands alone in that regard.
So there's a gap. We have this one crucial mechanical step, but nothing else right at the beginning to tackle the problem chemically or biologically.
That's the gap.
Which perfectly sets the stage for the second part of the research proposal. If immobilization slows the leak but doesn't stop it completely, what else can we do? Especially once that fat is already circulating.
Right. How do we build on that foundation?
This is where we get into enhancing protocols, developing more aggressive strategies. It's call to arms, really.
And this is where the two parts of the paper really link up beautifully. Part 2 builds directly on Part 1. The challenge is clear. FES is hard to diagnose early before the patient really crashes. So the radiologist becomes absolutely key. They're not just confirming a diagnosis after the fact, they're potentially making it before the clinical picture becomes obvious.
They become the early warning system.
Exactly. Relying on those subtle but specific imaging signs. They're like detectives looking for clues of this hidden danger. And this proactive role for radiology is central to the proposed research agenda.
Okay, so let's talk about those clues. What are the key imaging signs radiologists are hunting for? What tells them, uh-oh, this might be fat embolism?
Dr. Neymotin details several across different types of scans. It's like having a diagnostic toolkit.
Let's start with a CT scan of the chest, maybe without contrast.
Right, a non-contrast CT chest. Here, they're looking for that classic snowstorm appearance. It means you see these patchy, hazy areas, ground glass opacity scattered throughout the lungs.
Like looking through a foggy window, you said.
Exactly. And crucially, these patches are often in both lungs, bilateral, and they're not typically gravity dependent. They don't settle in the bottom of the lungs like fluid from heart failure might.
How does that help differentiate it?
Well, pneumonia often shows up as a denser, more localized patch consolidation, maybe in one lobe. Heart failure usually has that gravity-dependent fluid, maybe an enlarged heart. The diffuse, bilateral, non-gravity-dependent snowstorm is much more suggestive of something clogging the tiny vessels throughout the lungs, like fat microemboli. It's quite distinctive when you see it.
Okay, that makes sense. What about the brain, if you suspect it's gone there?
Then MRI of the brain is the gold standard, especially using specific sequences called DWI and FLAIR.
Diffusion-weighted imaging and fluid-attenuated inversion recovery.
That's them. They are very sensitive to tiny areas of injury or restricted water movement, which happens in microinfarcts. On these sequences, radiologists look for the Starfield pattern, and it really looks like that numerous tiny bright white spots scattered randomly throughout the brain.
Like stars against a dark sky?
Precisely. Each spot represents a tiny area of damage caused by microembolus, likely fat in this context. Seeing this pattern is a very strong indicator of cerebral fat embolism and signals an urgent threat to brain function, even if the patient isn't overtly showing major neurological signs yet.
That sounds incredibly powerful visually.
It is, and even a simple chest X-ray can offer clues, though it's less sensitive than CT.
What would you see on an X-ray?
Similar to the CT, you might see bilateral hazy areas, infiltrates, but importantly, they usually lack dense consolidation like you'd see in bacterial pneumonia, and there's usually no sign of an enlarged heart, which points away from heart failure. Again, it helps narrow down the possibilities.
And you mentioned an echocardiogram.
Yes, an echo with contrast specifically. This isn't primarily to diagnose the fat embolism itself, but to look for that potential pathway to the brain, the PFO, that patent foramen ovo.
Checking for the shunt.
Exactly. If cerebral fat embolism is suspected, especially with rapid neurological decline, confirming a PFO helps explain how the fat might have bypassed the lungs and reached the brain directly. It adds a crucial piece to the puzzle. So these aren't just pictures, they're critical alerts.
Right, they're not just interesting findings, they're red flags demanding action.
Absolutely. Dr. Neymotin's paper calls them triggers for immediate escalation. For example, seeing those diffuse bilateral lung opacities on a scan without any direct injury to the chest itself, patient broke their leg, but their lungs look like a snowstorm. You have to think fat embolism.
Makes sense. What else?
An MRI showing that Starfield pattern, those multiple tiny infarcts in the brain, again, with no history of head trauma. That's almost pathognomonic, very specific for microembolic events, likely fat in this setting.
And clinically?
Any new onset change in mental status confusion, disorientation, sudden combativeness, lethargy developing 24 to 72 hours after the fracture, that's a major red flag that needs immediate workup, including considering FES.
So these findings, especially the imaging ones, mean call the team now, even if the patient doesn't look critically ill yet.
Precisely. That's the core idea. Escalate immediately to the trauma surgeons, the critical care team. Don't wait for the full clinical picture to develop, because by then it might be too late. This proactive use of radiology, bridging that gap between subtle signs and overt crisis, is where we can make a huge difference. It's about integrating these findings into immediate life-saving actions. And formalizing how radiologists trigger these alerts is a key part of the research proposal.
Okay, so we have immobilization as the first step, radiology is the early warning. What about actually treating the fat once it's in the system? Can we use drugs? This gets us into that exciting area of pharmacologic interventions. But you mentioned earlier, there's currently no drug specifically approved for preventing FES after trauma.
That's correct. It's a significant gap in our toolkit right now.
So the paper explores potential candidates, drugs that exist but might be repurposed or need more study.
Exactly. Dr. Neymotin reviews several classes of medications that have been looked at or have theoretical potential based on how they might clear fat, reduce inflammation, or protect the blood vessels.
So if immobilization slows the leak and imaging spots the spill, can drugs mop it up, stop the inflammation, or shield the organs?
That's the hope. Let's go through the main candidates discussed. First up, corticosteroids. Methylprednisolone is the main one mentioned.
Steroids, right. How would they help?
They have a couple of key actions here. One, they are powerful anti-inflammatories. Since a lot of the organ damage in FES comes from that runaway inflammation, steroids could potentially dampen that response. Two, they seem to stabilize the capillary walls, make them less leaky, potentially reducing damage from the fat particles themselves and limiting fluid leak into tissues like the lungs.
Has this been studied?
Yes, some studies, particularly looking at prophylactic use in high-risk fractures, have shown a reduction in the incidence of FES. Not definitive proof, but suggestive.
But there are downsides to steroids, especially after trauma.
Absolutely. They can raise blood sugar, which is often already an issue in critically ill patients, and they suppress the immune system, increasing the risk of infection, which is a major concern after major injury or surgery. So it's a balance. Okay,
steroids are promising but have risks.
Yeah.
What else? Statins. Like cholesterol drugs.
Right, things like atorvastatin. The idea here is partly their lipid-lowering effect, but also their known anti-inflammatory properties, what we call pleiotropic effects.
So maybe a dual benefit again?
Theoretically. But the paper notes this is mostly theoretical in the context of acute FES. We don't have much data on using them acutely for this purpose in trauma. Most statin benefits take time.
And side effects.
Potential liver enzyme issues, muscle pain, things you'd need to monitor carefully in an already sick patient. More research is definitely needed here.
Okay. Then you mentioned lipid emulsion therapy. That sounds different.
It is. This is currently used mainly as an antidote for overdoses of certain fat-soluble drugs, like some local anesthetics.
How does it work?
It essentially acts like a lipid sink. The emulsion particles circulate and literally trap or absorb other lipid molecules, like the drug molecules in an overdose, or, theoretically, the fat emboli in FES.
So it could potentially just soak up the fat from the bloodstream.
That's the proposed mechanism. It's a fascinating idea, directly targeting the fat itself, but it hasn't really been studied specifically for FES prevention or treatment in humans. It's a promising avenue, but unproven right now.
Any risks with lipid emulsions?
Rare allergic reactions, maybe fluid overload or effects on lab tests, but the potential to rapidly clear free fat makes it very intriguing for future research.
What about heparin? Isn't that a blood thinner?
Yeah.
Seems risky after trauma.
Exactly. Low-dose heparin has been looked at historically. The theory was it stimulates an enzyme called lipoprotein lipase, which helps break down fats in the blood.
Speeding up the natural cleanup process.
Yeah. Right. But the studies yielded inconsistent results. And the big drawback, as you said, is the bleeding risk. Giving a potent blood thinner to someone with major fractures and potential internal injuries is generally not a good idea. That risk usually outweighs any potential benefit here.
Makes sense. Any others mentioned?
The paper briefly touches on alcohol infusion as a historical approach. The idea was it might alter fat droplet properties, but it's firmly categorized as obsolete and not recommended due to serious side effects like CNS depression, making patients dangerously drowsy or unresponsive. It's a good reminder of how treatments evolve and why we need rigorous study.
Okay, so looking at that list with the pros and cons, which one seems like the front runner right now, according to the paper?
The paper clearly leans towards corticosteroids, specifically methylprednisolone, as the best current candidate for focused research.
And why is that? What makes it stand out?
Several reasons. First, the potential for a relatively rapid onset of action within hours, which is critical in acute trauma. Second, that dual mechanism, tackling both the inflammation and potentially stabilizing the blood vessel walls. It addresses two key parts of the problem.
And third, there's some existing clinical data, even if limited, suggesting a benefit in reducing FES incidence. It's not purely theoretical.
Right. It has a plausible mechanism, potential speed, and some preliminary supportive evidence.
So based on this, Dr. Neymotin actually proposes an experimental protocol to test this properly.
Yes, a specific protocol for a clinical trial. The proposal is methylprednisolone, 1 gram IV infusion over an hour.
1 gram, okay. And when would it be given?
Within 8 hours after the injury, specifically in patients identified as high risk for FES, and critically, only after ruling out major contraindications like active infection or uncontrollable bleeding.
And this is strictly a proposal for research, not current standard practice.
Absolutely. It's a hypothesis to be tested rigorously in well-designed clinical trials. But it represents a concrete step toward potentially finding the first effective pharmacologic prevention for FES. Here's where it gets really interesting. Thinking beyond single drugs.
Right. You mentioned the paper looks at combining therapies.
Exactly. Moving towards synergistic combinations. The idea being, if different drugs tackle different parts of the problem, using them together might be much more effective than any single agent alone.
A multi-pronged attack. Makes sense. What combinations are suggested?
One idea is corticosteroid plus a statin. You get the strong anti-inflammatory effect from the steroid, plus the lipid-lowering and additional anti-inflammatory effect from the statin, a double hit.
Okay, tackling inflammation from two angles, maybe lipids too.
Another one is corticosteroid plus lipid emulsion therapy.
So controlling inflammation with the steroid, while the lipid emulsion actively traps the fat in the bloodstream.
Precisely, hitting both the response and the trigger.
That sounds quite comprehensive.
And perhaps the most aggressive concept mentioned is combining lipoprotein lipase inducers drugs to speed up fat breakdown with actual blood filtration.
Wait, filtering the blood, like dialysis for fat.
Essentially, yes. Using extracorporeal methods, processing the blood outside the body to physically remove the fat, while also using drugs to help the body clear what remains. That's a very direct, aggressive approach for high-risk cases. These combinations really represent next-level thinking.
Beyond combining existing drugs, does the paper suggest exploring totally new types of medication?
It does. It points towards several classes of novel pharmacologic agents that warrant investigation.
Like what?
One group is fibrates. These are drugs already used to lower triglycerides and improve fat metabolism. The question is, could they work fast enough and safely in acute trauma? We don't know yet.
Okay, targeting fat metabolism. What else?
Apolipoprotein mimetics. These are fascinating. They're engineered molecules designed to mimic natural proteins that bind to fats.
So they could potentially act like little sponges, binding to the free fat droplets before they can cause blockages.
That's the idea. Directly neutralizing the fat emboli themselves. A very targeted approach.
And anything else?
Monoclonal antibodies. These are highly specific antibodies designed to target particular molecules. In this case, they could be engineered to block key inflammatory mediators involved in damaging the blood vessel linings after fat embolism.
So intervening directly in the inflammatory cascade at a molecular level, very precise.
Exactly. It represents a shift towards highly targeted, sophisticated therapies designed for the specific pathways involved in FES. Really cutting-edge stuff.
Wow. But the innovation doesn't stop with drugs, does it?
Yeah.
The paper also looks at non-pharmacologic, sort of technological solutions.
It does, and this section really opens up some futuristic possibilities.
Yeah.
Technological frontiers in trauma care.
Like what? Give me an example.
Okay, imagine a real-time fat embolism detection tool. Think maybe a portable ultrasound device or something using spectroscopy that a first responder or ER doc could use to directly detect lipid signatures in the blood right there at the point of care.
Instant diagnosis, before symptoms even start.
Potentially, yes. That would be revolutionary for triggering early, targeted interventions.
What else? You mentioned blood filtration earlier.
Right. The paper proposes immediate microfiltration or hemoperfusion as a potential therapy, not just a theoretical combination. This would mean having systems ready, perhaps in major trauma centers, to rapidly filter the blood of high-risk patients to remove fat particles, maybe even prophylactically based on injury severity. A very direct intervention.
That sounds incredibly invasive, but potentially life-saving in extreme cases.
It would be reserved for the highest risk scenarios, yes. Then there's the idea of smart splints.
Smart splints, like with Wi-Fi.
Maybe not Wi-Fi, but integrated sensors. Sensors that could monitor, say, blood flow or tissue oxygenation around the fracture site, or maybe even detect subtle signs related to fat migration risk. It would make that first line of defense immobilization much more intelligent and informative.
Giving clinicians real-time data from the splint itself.
Exactly. And perhaps the most forward-thinking idea is field-administered microdose steroids or lipid sequestrants.
Putting the drugs right in the first aid kit.
Essentially, yes. Having agents like low-dose steroids or maybe even a lipid binding agent available in trauma packs or splint kits for immediate administration by paramedics right at the scene.
That's pushing the intervention right back to the moment of injury.
It's the ultimate in early proactive treatment, preventing the cascade before it even really starts.
These are incredible ideas, new drugs, combinations, tech, but they all need testing, right? What research does the paper say is needed to make these happen?
Crucially, it lays out key research questions. It's not just blue sky thinking, it's a roadmap for validation. A major one is figuring out the optimal timing and dosing for any promising drugs, especially corticosteroids. When exactly after injury? What dose hits the sweet spot between benefit and risk? These details are vital for safety and efficacy.
Absolutely critical. What else?
Developing a reliable risk scoring algorithm.
A way to automatically identify high-risk patients.
Exactly. Using factors like fracture type, patient age, their initial vital signs, maybe even early imaging findings to generate an automatic alert for FES prophylaxis.
So the system flags the patient for the team. This person needs closer monitoring or potential preventive therapy.
Right. It streamlines decision-making, makes it more objective, ensures high-risk patients don't slip through the cracks.
And connecting back to radiology.
Yes. Establishing formalized radiologist-led alert protocols. Clear, standardized procedures for how radiologists communicate those critical early imaging findings, the snowstorm lungs, the starfield brain, to trigger immediate coordinated action from the entire trauma team. This raises an important question. how do we best weave that diagnostic power into the real-time flow of emergency care?
So wrapping this all up, it's really clear that this two-part paper is much more than just an analysis. It truly is a comprehensive medical research proposal.
Absolutely. It connects the dots.
We've gone from understanding the danger, the fat embolism itself, the severe FES reaction, and the vital role of just basic immobilization, all the way to these advanced concepts. Radiologists as early detectives, potential drug therapies like steroids or lipid sinks, innovative combinations, and even future tech like smart splints and blood filtration.
It's a whole spectrum of intervention, from basic to highly advanced.
And it paints a picture of real collaboration needed, emergency docs, trauma surgeons, radiologists, researchers all working together. So what does this all mean, big picture?
Well, it means that while something as fundamental as immediate immobilization is, and will likely remain, absolutely critical, medicine doesn't stand still. This deep dive shows that push from basic stabilization towards much more sophisticated, layered strategies, trying to neutralize these hidden threats right at the source, or very early on.
Moving from reactive to proactive.
Exactly. It's about anticipating and intercepting the problem before it escalates into a full-blown crisis. And, consider how this whole approach, starting with a simple field action, then layering on advanced diagnostics, potential drugs, future tech, might apply elsewhere. It reflects a shift in thinking. What other unseen complications, maybe outside of trauma, could benefit from this kind of comprehensive, research-driven proposal that bridges immediate response with future innovation? It really makes you think about how we tackle complex medical challenges across the board.